I'm Patti Costello.
And tell me about your position.
I'm the Executive Director of the Association for the Healthcare Environment. It is a personal membership group that's a part of the American Hospital Association. The personal membership groups, there are 9 of them, and they each represent a discipline that exists within a hospital, from support services or engineering, plant operations, environmental services. So we are one of those personal membership groups.
And how did you personally become interested in the healthcare environment?
That was my field of study in college.
Oh, really?
I went to nursing school.
Uh-huh. And what made you choose it in college? Why?
My grandmother lived with us when I was a child, and she got very ill, and I helped my mom take care of her. She died when I was about 9 or 10. I think it was 9 or 10. And I just loved taking care of people. And I never wanted to do anything else. What was ironic is once I got to the place that it was time to finish, I didn't want to do it anymore.
But now you're really making a difference in the healthcare environment. Your whole life is about making a difference in the healthcare.
I parlayed all that experience, all that knowledge, and placed it elsewhere, which is very exciting for me. I hope it's exciting for the AHE members, because I think I bring a little different perspective to the table. Having worked in a hospital, having trained in a hospital, but not having the RN or that kind of background, I have more of an operational background. So I think blending the two together makes it very interesting for them.
And so now tell me about the healthcare environment, and tell me what are the big issues that your members are facing? What are the...
Well, it's progressed from being just cleaning a healthcare facility, making the floor shine, and the pictures look pretty, and cleaning the textiles, talking to patients. Now it's really escalated into how does the environment play a role in the transmission of infection. And now with all of the changes, regulatory changes, particularly with CMS and reimbursements, pay for performance, it's very, very important that the environment is kept clean on a regular basis, that its high-touch areas are taken care of, and that patients and the workers collaborate to make sure that they have the very best care environment for patients and visitors.
When did it make that transition that you just described?
It's ironic because we've been talking about it for years, and I think it has a lot to do with my background and knowing about microorganisms and knowing where they breed and the type of vectors. And I think that's what I brought to the table. So we've been talking for years about, well, if the OR isn't clean, the surgeon can't cut. If the patient environment isn't clean, especially in inserting catheters or surgery, and no one ever, they didn't take it seriously. And I don't know what it was that actually prompted, I'm assuming it was research. That's all I could think of is that Dr. Ritala, Dr. Weber, a lot of the research that some of these gentlemen and some of the best minds in the business have done, I think has helped push it along.
And approximately when? Is this in like the last 5 years? Is it...
I'm going to say 6 or 7. Last 3 really hot and heavy.
And so the other side of that is that now there's a lot of pressure because there's a lot of, right, when you're doing more than just clean the tiles, it's like we want to make sure we're doing this right.
Well, the interesting thing is the facilities are not focusing on the AHE members. They're focusing more on the clinicians. Administration still hasn't quite gotten the message. At least I don't believe that they have. Seeing what I've seen and hearing what I'm hearing from our members, while there's a lot of pressure on turning rooms quickly, there's a lot of pressure on them to make sure that the turnover rate is at a place that they need it to be so that the patients can keep moving through the system. It's administration just isn't seeing the fact that you can't cut the highest labor department of the hospital and still have the best patient outcomes. We're not quite there yet. What I'm hoping is that the collaborative effort that we're involved in with APIC now will take the 2 organizations together and help them move that agenda forward.
So I just met with Marita and Kathy, who we were on the phone together with. They're obviously an exceptional group, right?
No, they're a great team.
What I'm hearing from you is they are the exception. Is that true?
I don't know. I don't think I'd classify it as them being the exception. I think they're just doing it better than anyone else. And having spoken with Marita is a member of AHE. She has told me numerous stories about her relationship. They've spoken together at conferences. They just do it better than anyone else. And that's a great role model for the rest. We believe that our members are in fact collaborating with infection preventionists, and I believe APIC knows that their members are as well, just not at the levels that we believe is necessary.
One of the things that Kathy and Marita told us about was how they formed a really effective duo to convince the administration that resources were needed in environmental services. And that's kind of what you just said, only you're talking about APIC and AHE.
Correct. I don't know that infection preventionists and environmental services independently have the resources or the wherewithal to know what to ask for. And the reason why I say that is infection preventionists are fighting the same battle that environmental services professionals are with regard to staff cuts. So if you looked at what the benchmark is for the number of IPs per number of beds, it would be pretty much the same thing that our members are dealing with, how many FTEs that they should have given the number of beds. So they're fighting a lot of the same battles. So they don't have the resources independently. They really do need to work together. So Marita and Kathy did a great job of being able to say, here's the business case. This is why we need this, and this is what the return on the investment will be.
So tell me about what you're hoping for as we look to the year ahead. This roundtable is a kickoff. What do you hope will come out of this? What's the best possible scenario?
I think there's a couple. One is the members of both organizations will see that we are now walking the talk. APIC has told their members, you need to be collaborating with environmental services. AHE has been saying to its members, you need to be collaborating with the infection preventionists. And oftentimes our members would come to us and say, well, why aren't you collaborating with APIC? So I think now that they're going to see that we're walking that talk, that will be one of the biggest benefits. I think secondarily will be the educational tools that will be made available to both professions about how to collaborate, how to work together in getting the best outcomes. That's my hope.
And what is talk to me a little bit about the benefits of when they do collaborate, besides convincing the administration of the importance of resources. Where do we see the impact of collaboration between these two groups?
Better patient care, better turnover of rooms, better product selection, lower infection rates, hopefully, and just the human dynamic when you're working hand in hand, when you're working truly as partners, you have the same goal. And when you have the same goal, you're going to do the same things every single time. And consistency in infection prevention is what's needed. That's why you hear so much about checklists. Checklists for everything. When you do the same thing the same way every time, your outcomes are always going to be better. So I think the more our two organizations collaborate, the more our members collaborate, doing the same things frequently, the outcomes, I think, will be much better.
How are best practices shared within AHE among your members right now?
We actually have a manual that is practice guidance for healthcare environmental cleaning. It's been reviewed by infection preventionists. It has been tied to competencies. For example, what do environmental services frontline workers need to know about reporting someone that they may be working with or someone they're coming in contact with that might have the flu or might have flu-like symptoms? What do they need to do and how do they go about reporting that? So we've tied a lot of the work to very measurable competencies, both cognitive and behavioral. The other part of the practice guidance is that it gives you step-by-step, do this, do this, do this, and then it also tells you what type of tools that you should use. So we've established some best practice around the types of equipment, the types of, not necessarily products by name, but certainly tools and equipment.
What are the challenges, you think, for collaboration between the IPs and the EVS?
Oh, sometimes I think there might be some territorial issues, and I think that's pretty natural, particularly when you've never worked together on a regular basis. You may interact around a committee, or you may interact around a education program in the hospital for frontline staff. But when you're doing it on a regular basis, for the ones that are not really interested in collaborating, or they don't see the mutual level of, there isn't the mutual level of respect, that may be a problem. But for the most part, I think we've got two great organizations who have members that are very professional and very committed to what they're doing. So I really don't see problems in the background. I see mostly positive.
And so what are the areas of opportunity?
education, training, information. The more information the field has, the better the outcomes. The more training, the more education, the better the outcomes. We're all lifelong learners, and if you're not going to approach it from the perspective of, I always have something new to learn, I always can do this better than I did it the last time, that's probably the best opportunity is the education and training for both sides, because our members bring a different perspective to the table, which is the operational and practical side, and the APIC members bring the clinical perspective. And you meld the two together, and now you've got one really strong program.
Talk to me more about the strengths that that your members have, so that I can understand that partnership more clearly.
Probably practicality. We do a lot of things based on evidence, obviously. You want the best research, you want the best data to make the best decisions, but we have a practical side to us. We will look at it and say, well, yes, you want us to clean those 110 IV poles or infusion pumps, and let's just say it takes 7 seconds to clean that infusion pump each time we do it. You calculate that out to how long it takes. In a year, that may mean I need another FTE just to clean those infusion pumps. So they're looking at it from a practical perspective. Yes, they want the same outcome. Yes, they know that that should be done. But if they don't have the resources to do it, they can provide that practical side by just making it very simple. And I think that's a very important perspective.
Of course it is, yeah. One of the issues that I've heard in talking with folks has been treating the environmental services people as if they were second-class citizens, or not giving them the peer equity, if you will, in the relationship. What do you think is the best way to handle that? How can we raise the awareness and improve that situation?
I think this collaborative effort will do that. I think it'll highlight who AHE is as an organization. I think there's a lot of professionals that are out there that don't even know we exist. They don't realize that there's a membership organization very similar to theirs that trains, that provides information, that provides best practice, provides data and research, very similar to what APIC does for their members. Once we can get out into even the overall healthcare facility, hey, these are not just broom pushers or mop pushers. These are managers. These are people with college degrees. They have a very operational perspective, yes, but they still know as much about their work as you know about your work. So I think that's a very important piece that I hope that we'll get out of this, is that they'll realize these are not the frontline workers, these are not the frontline technicians, they're managers, they're directors, they have master's degrees in many instances. We have members that have PhDs. Which is quite interesting. So they're educated people who take their job very seriously, and they're very committed. You have to love this job to do it right. I call them the Rodney Dangerfields of healthcare. But it's true, and you really have to love it, because when you think about the work that they do and the people they manage, it's not something that you might aspire to do when you grow up, so to speak. But we're about to change that.
Yeah, tell me more about that.
Well, we've developed a progression model from frontline work all the way up to the manager-director level. We're hoping to assist those that have not finished college to finish their college degree, those that have to work toward a master's degree, working toward a fellow program. So we have an entire model, a progression model, if you will, that we will be continuing to build our education programs around. We've recently hired an education manager who has a master's degree in instructional design. So we're very serious about providing the education and training that's necessary to gain that respect that we've been talking about, because you do have to earn it. It isn't just given to you.
There's so much technical expertise required in this field.
Absolutely. Cleaning is a science. It's not just picking up a mop and a towel or a rag. It's a science. It's about moving undesired matter from an undesired location to a more desired location. And there's a way to do that, and there's a way to do that properly. There's also the science to the disinfection piece. How do you kill certain microorganisms? What products work against other microorganisms? You don't use the same products against all microorganisms, especially when you know it exists. So it's a science, and the clinical background that the APIC members bring, or the infection preventionists bring, is very important to helping our members understand that science even better.
I'm struck by how rapidly technology and chemistry breakthroughs are happening. How do people stay current in that field?
We provide a lot of the information. We stay in tune with the research. AHE as an organization is very, very plugged in and connected to the regulatory agencies, those that provide the label registration claims for chemicals. We're very involved with them. We're involved with equipment manufacturers. So we try to stay on top of it, and then what we do is we try to plug into the folks that do the testing and collect the data around new product technologies, whether it's chemicals or whether it's actual machinery. There's a lot of interesting equipment and tools out there, but you could sell just about anything if you want to. You really need the data, you need the research, you need the studies, you need the information. So that's the piece that we bring to our members. And then we don't tell them what to use, we just provide the information, and then they can decide based on the best information.
It seems like that would be an area of opportunity too, that some of that information would then get shared with infection preventionists in APIC. You have this massive amount of information that's coming.
Well, that's one of the ways that APIC and AHE in the last couple of years have collaborated with each other. We've responded to the Environmental Protection Agency collectively around label registration claims or research for companies that are looking for certain registration claims around certain microorganisms for their products. We've responded jointly with APIC and another organization, so there were 3 of us, with the Food and Drug Administration around cleaning of medical equipment. So together we could make the best choice or the best decisions around, here's all the information, lay it out on the table, show them the pros and cons, the advantages and the disadvantages, what works, what doesn't, what the challenges are, and then you decide based on the culture or the environment in your facility. So that's the role I think we could play together between the 2 organizations.
You've chosen Ruth Carrico, I believe, to be your lead clinical advisor.
That's correct.
Tell me a little about that choice.
Ruth did a study at the University of Louisville in Kentucky around competencies for non-clinical healthcare workers. And one of the pieces that Ruth tied to was our practice guidance manual, the practice guidance for healthcare environmental cleaning that I mentioned earlier. And she was actually able to match up the competencies that she did or was able to validate through her study. She was able to match those up within our practice guidance. So that's how we got to know Ruth. 2 of our members had actually participated in that study, unbeknown to us, and then it all flushed out as we saw, wow, this is a really great study. Who was on the study? I saw an abstract, and then I noticed that there were some names there that I recognized, so I called Dr. Carrico and told her who I was, and she got all excited, and so she validated what we had put out there as practice guidance through academic research. So that's really why we selected Dr. Carrico. She knows the membership, she knows what they do, she has a great amount of respect for the profession and the field, and I think she'll represent us well.